Living with lithium, that is, with its side effects, and adolescent substance abuse issues. The two topics on Audio Digest Psychiatry, Volume 24, Number 10. Your last issue began a review of side effects of lithium by James W. Jefferson, Distinguished Senior Scientist at Dean Foundation for Health, Research, and Education, as well as Clinical Professor at the University of Wisconsin. Dr. Jefferson continues that review now, looking first at renal effects of lithium.
The kidney and lithium is a topic that goes back for years. There have been probably 1,000 articles written about it. I thought I would illustrate it by one of my patients who is now 55 actually. He had his first manic depressive episode in 1959, and between then and 1974 he had had 11 hospitalizations and had spent almost 2.5 years of his life hospitalized. That's bad. The next 20 years on lithium, he had no hospitalizations, he had no outpatient episodes, he remained steadily employed and got married. Not a bad outcome. So when people say 3 or more previous episodes predicts poor response to lithium, it probably does, but not in everyone. So there he was, and a success story. It sort of makes you want to stand up and cheer until you look at his kidney function, which is the other side of the coin. It looks as though he paid a price for euthymia, and he has rather consistently put out 4 to 5 liters a day, 24-hour urine volume. And if you care to know how much most of us put out, we probably put out 1 liter or 1.5 liters on a good day, and maybe less than that if we're running around in meetings. Polyuria is not too bad. The serum creatinine went gradually, little by little by little, from a normal 1.3 to an abnormal 2.0. And during this passage, his creatinine clearance dropped from 112 to 61. For that age, creatinine clearance is probably around 80. For that age, serum creatinine is 1.3 as upper limits of normal. So he has modest impairment of renal function. He has what I've labeled the creeping creatinine. How many people have patients who are on long-term lithium whose creatinines are just sort of working their way up? And that's exactly what happens. And you read the literature, and the literature says long-term lithium use is no associated decrease in GFR, and that's true in the large studies, but I think there are enough atypical patients out there that this is not an uncommon picture at all. And the question that will come up is, when do you pull the plug with lithium? How high does the creatinine get? How low does the clearance get? And as far as I can tell, that's a very individual decision you reach with patient, nephrologist, and psychiatrist. This particular patient is remaining on lithium because there's no way I could guarantee him 20 years of euthymia on an anticonvulsant drug, and we're monitoring his kidney function rather closely. Now, let me point out that there are many other causes of impaired renal function. And the title of this is chronic interstitial nephritis. The newer name is tubulointerstitial nephropathy. So I suggest you write that down, because if you just say it to patients, they'll think you know more about everything than anyone else they've ever met. Tubulointerstitial nephropathy, this is out of a nephrology text. Drugs and toxins including lithium, hematologic, hereditary, immunologic infections, obstruction, and metabolic disorders. And unfortunately, not on the list is that little category called idiopathic. And this is why patients with the creeping creatinine should have an evaluation by a nephrologist to be sure they don't have one of these other conditions that is being confused with effects of lithium. Now let me jump to polyuria. This is really the most common clinically troublesome renal side effect of lithium. People put out a big urine volume, usually because lithium has effects blocking ADH on the kidney. It's less common at lower lithium doses and blood levels, so if you can get by with a lower level, fine. Single daily dose was thought to be associated with lower 24-hour urine volumes, and unfortunately more recent studies have confused this issue, and it's unclear whether single daily dose is any safer in terms of polyuria. Diuretics are the standard drug interventions to reduce urine volume in nephrogenic diabetes insipidus. Thiazides are no longer considered the drugs of first choice because they cause hypokalemia in lots of patients, and in addition, thiazides can contribute to hypercalcemia. So two problems that don't go well in combination with lithium. So generally, it's recommended that a potassium-sparing diuretic, namely amiloride, either alone or, if it doesn't work alone, in combination with the thiazide, be used to treat the diabetes insipidus. The lithium level will usually go up in the presence of one of these drugs, and the oral dose will have to go down. Now, if that doesn't work, there's some evidence that indomethacin in a dose of 50 milligrams once to 3 times a day will rather quickly and effectively lower urine volume. It will also increase serum lithium level. Potassium back in the picture again. Never let serum potassiums get low in lithium patients, but again, potassium supplementation is seldom necessary. DDAVP, synthetic vasopressin analog, can be snorted, and in patients who have some central component to the mechanism of polyuria may benefit from DDAVP. This is uncommon for this to be effective. And here's inositol again, in a report of about 6 patients from Israel in whom 1 gram 3 times a day in an open study seemed to reduce urine volume. Seems safe, seems easy, and everyone is curious to know if it really works. Well, we're back to pregnancy. The good news, lithium is not quite as bad as all that. That's the good news. Here's a study, prospective controlled study of 143 patients exposed to lithium during the first trimester. There was no difference between lithium babies and controls in terms of number of live births, number of major anomalies, number of abortions, number of ectopic pregnancies, number of preemies. Pretty nifty. But there's always a downside. Lithium babies were fatter. Lithium babies on the average weighed 92 grams more than control babies. The other problem was the 1 case of Ebstein's anomaly, which has always been the cardiovascular defect linked to lithium, happened to occur in the lithium group and not the control group. So all I could say was the risk does not appear to be as high as it once was, but clearly the risk is not 0. And in the most recent review of this, which was an article in the AMA Journal in '94, January 12th, this is basically where the figures are. The risk of major anomalies is somewhere between 4 to 12% in lithium babies. In control babies, it's somewhere between 2 to 4%. So it looks like lithium increases risk by 2 to 3 times. 2 to 4%. If you do nothing, if you give your patient nothing, that risk is there. Keep that in mind. But if you give the patient something, they're always going to blame you. They'll forget there's a 2 to 4% risk. Now, after the first trimester, patients tend to tolerate lithium reasonably well during pregnancy, and higher risk patients should go back on the drug after conception. At the time of delivery, the recommendations in the past had been discontinue lithium shortly before delivery to allow the baby to be born with the lowest amount of lithium present. The concerns now are that abrupt discontinuation of lithium may place the mother at markedly increased risk of a manic episode. And listening to Lee Cohen talk, he has been recommending that one lowers the lithium dose without discontinuation as delivery approaches and bump it back up very quickly to therapeutic postpartum, because the risk of postpartum manic or depressive episode is about 50% in bipolar women. And because they're back on lithium, breastfeeding is generally discouraged because of the presence of lithium in breast milk. Keep in mind that taking people off mood stabilizers can have unpleasant consequences. And here's a woman who got pregnant on lithium. The drug was discontinued. She had a psychotic relapse within 4 days, and she killed her 3-year-old child. So these are very difficult decisions to make. It's not just pregnancy, no drug, and that's it. It's weigh the consequences of going in either direction and let the individuals be aware of that. Well, a little bit about skin, because skin, unlike kidneys, is very closely tied into body image. Patients do not like to look poorly. So if lithium aggravates acne, which it can do, non-compliance. If lithium makes psoriasis worse, non-compliance. Derriere's disease is actually a follicular keratosis that is rare but aggravated in the presence of lithium. So if you think acne bad, psoriasis bad, Derriere's disease bad for patients who are being considered for lithium treatment, the good news is that lithium will suppress herpes simplex both orally and genitally, has an anti-herpetic effect. And a lithium ointment has been shown to improve seborrhea. Now, the last area I want to touch, and I'll do this very briefly, is this whole area of drug interaction. Nobody takes one of anything anymore. The drug interaction issue starts with diuretics. Thiazides increase lithium level virtually all the time. Potassium-sparing diuretics have not been thoroughly studied in this regard, but the weight of the evidence says that they will tend to increase lithium levels. The loop diuretics don't. The loop diuretics, at least when studied in normal individuals and also in hypertensive individuals, tend not to change renal lithium clearance, and lithium levels tend to stay the same. Osmotic diuretics and xanthine diuretics can lower lithium levels. Keep this in mind if you're treating an asthmatic patient who's on theophylline. It will take a bigger lithium dose to get the blood level you want in the presence of theophylline. The patient happens to stop theophylline, the lithium levels will go up. So drug interactions occur starting and also stopping medications, and you have to be aware of that. Here's a classic case. Lithium stabilized at 1,200 milligrams a day, a perfect level of 1.0 until the thiazide pops into the picture. And here's the patient now at about 2.3 and confused, appetite loss. And the doctor says, boy, we better stop these drugs. And they did, and the lithium level dropped to nothing, and the patient went from confused to manic. And then back on the drug. And basically what one can do in these situations is restabilize the lithium dose in the presence of the interactive drug, and you can continue these interacting drugs, but you have to do it at a lower lithium dose. It's a very simple, obvious interaction, and it often gets ignored. Non-steroidal anti-inflammatory drugs do not go well with lithium. In most situations, lithium levels increase slowly on non-steroidals. It does not occur with aspirin, and it does not appear to occur with Sulindac, Clinaril. But otherwise, assume it can happen with anything. The risks are greater in geriatric patients, on higher doses of non-steroidals, and in the presence of any pre-existing impairment of renal function. So even over-the-counter ibuprofen may, in a susceptible patient, bump the lithium level up. And patients think anything over-the-counter can't be harmful. And this is why patient education is really vitally important. And those of you who take 800 milligrams of ibuprofen 6 or 7 times a day because it can't do any harm, look what non-steroidals can rarely do. Rare. They can cause sodium retention. About 3% of people will develop edema. They can cause hyperkalemia, acute renal failure, nephrotic syndrome, and papillary necrosis. So this suggests even these so-called benign drugs require some type of monitoring if patients are on lithium. The last category are the so-called ACE inhibitors, angiotensin-converting enzyme inhibitors, which are widely used in all sizes and shapes in primary care medicine and cardiology to treat hypertension and heart failure. And these drugs will probably semi-predictably bump lithium levels up. Here's what happened in 4 separate patients who prior to an ACE inhibitor had lithium levels around 1. Several weeks later, because of the drug interaction, were lithium toxic with levels of 2 to 3.3. So once again, assume an ACE inhibitor will bump lithium levels up and monitor the patient.
Now, some issues in management of substance abuse in adolescents by Robert B. Millman, Saul P. Steinberg Distinguished Professor of Psychiatry and Public Health, and Acting Chairman of the Department of Public Health, Cornell University Medical College. Dr. Millman?
Just another night on Crack Street. There were a whole series of shows on TV, incredible production values, really exciting, loud noises, weird light. A kid living in inner city project in Detroit says, whew, that's where the action is. At any rate, the media, our own sense of romanticism, our tendency to idealize living on the edge have made drugs very exciting. They always will be, particularly to the kids, and that's where drug use begins mostly. It's very interesting that those of us who have been in the field for a long time, we watched this epidemic happen, and we were talking about it earlier. In the 60s, there was no drug use. You know, people didn't use drugs. Certainly middle-class people weren't using drugs, and the numbers of kids who used marijuana or used coke was remarkably small. And then early, mid-60s, the rise began, an epidemic began, looking like it was going to continue such that by 78, 79, probably 60, 70% of kids, high school kids, were smoking pot, many were using lots of other illicit drugs, and there was a fair amount of cocaine, although cocaine peaked a little bit later. And looking at it, living there, the sense was that there was no reason for the numbers to ever go down. It looked as if it was going to continue to rise. There was no reason for it to stop. That was 79. Then for some reason, it started to decline. Cocaine rose a little bit later, and then it started to decline as well. And it's interesting, we didn't really know the reason for the rise, and we also didn't know the reason for the decline, although all kinds of politicians talked about war on drugs, winning, losing, I don't know. But we could make up some reasons for the rise. The rise might be due to Vietnam War, breakdown of conventional morality, rebelliousness on the part of kids, questioning authority, saying our parents have gotten into this mess, who cares what they say, better living through chemistry, development of new psychotropic drugs, a whole variety of things conspired to make it kind of exciting for young people and older people to take substances. You could change the way you were. The world could be anything you wanted it to be. You didn't have to hold on to an unchanging view anymore that was true of the preppy 50s. Now it was a loose, flexible kind of world that you could go anywhere or do anything. The trouble is, there was a reaction, and by 79 everyone was realizing, or lots of people were realizing, it doesn't work like that. You still have to get a job, you have to get an education. We see all the casualties of the drug wars, and drug use decline. Over this past year and a half, a new phenomenon is occurring. As we were all congratulating ourselves on this changing view of morality and how things have become conventional again, drug use seems to be on the rise. And this data is from what we all know to be the Monitoring the Future study, or it's called the National High School Senior Survey. And it's truly a tour de force of epidemiology. It's a remarkable thing. Extrapolative survey where they looked at something like 50,000 kids in 400 schools, selected purposefully to try to get an idea of the rest of the kids. At any rate, looking at it a different way, used any illicit drug other than marijuana, again, peaked in 78, 79, 80, declined remarkably over the next 10, 12, 14 years. And then over the past couple of years, there's been an increase of all illicit drugs and all illicit drugs other than marijuana. Clearly, as we all know, alcohol and cigarettes are the most important, but marijuana is a contender, 35% of 8th, 10th, and 12th graders. There's another way to look at what's going on. 6th, 8th, 9th, 10th, 11th, 12th grades, they all show the same rise to 79 or so, and then decline to the last year or two, and then this funny little peak, funny little upsurge in all the classes. Except for the inhalants, drug use tends to increase in kids towards the 12th grade and then begins to decline by, say, age 25, where much of the drug use is gone. Inhalants are interesting in that the younger grade levels use more inhalants than they do the other illicit drugs, probably because inhalants are easy to get, they're cheap. Another way to look at the data is thinking about cigarette smoking. I mean, here, this is clearly the most lethal health menace. It's the #1 cause of premature preventable death in our world. We're all congratulating ourselves on how cigarette smoking decreased, and now it turns out that cigarette smoking is on the rise in all the grades, girls more than boys, but all the grades, and it turns out that the disapproval rates or the harmful rates are remarkable. Like in some surveys, 30, 40, 50% of the kids said they didn't think smoking cigarettes was very dangerous. I thought that's pretty interesting. And this is very interesting. This is trends in disapproval of marijuana use for 12th graders. Percent saying they disapprove of using. So in 79, when use was the highest, the least number disapproved. But now when we get to 92, 93, the numbers disapproving are declining. The numbers saying great risk from using pot regularly, occasionally, once or twice is declining. Quite interesting. It's as if they've forgotten the lessons of the 70s and 80s, or they've heard it so much that it's become trite and boring. Disapproval of cocaine use, same deal, only cocaine's a little more stable. Perceived harmfulness of cocaine use. I would predict that cocaine use will start to rise again based on the softening of attitudes towards these drugs. Availability of marijuana versus the perceived risk, which is declining. against use, which is increasing. Cocaine, use levels are just about to rise. Risk is going to decrease. Availability seems to be staying the same. We have a new culture on our hands that's romanticizing drugs, excited about the possibility. Guys like Johnny Depp going out with Kate Moss, and even Kurt Cobain dying, lead the kids in Queens and in Detroit and all over the place to think that drugs are exciting, they are cool. This is a way to be part of an interesting society. There are no contenders. I think, however, we have to question the study. The drug use went down. Now it seems as if it's going up. During that whole period when it was going down, we were saying great, 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 but I don't even believe that's true. Turns out that in the inner city, in New York and Detroit and Miami, truancy rates are often 30, 40, 50% in different areas. And what they do in New York, and I don't know about Philadelphia, but what they do in New York is when kids don't go to school for a period of time, they drop them off the rolls. There aren't enough truant officers anymore, so you don't go after them. They drop you off the rolls, so that means there's much less truancy if you drop 20, 30, or 40% of the kids off. And those kids are not taken into consideration by the tour de force I mentioned, the high school senior survey. What I think is really interesting is, this is old, but it holds, is that drug use, cocaine use in this case, increases per absence, by the number of days absent. So even though they were monitoring this remarkable decline in drug use, and that was true in the kids who went to school, there was a large number of inner city and not inner city people who weren't going to school, who I suggest continued to use the drug. And another way to think about it is that drug use in adolescence went from an epidemic situation to an endemic situation. An epidemic is something that sweeps across the society, hits everybody. An endemic situation is a situation where the illness, the bug, the bacteria, the virus lives in the population and attacks those who are at risk. And that's what's been happening over the past 15 years. It's been attacking the poor, the disadvantaged, or the psychiatrically disadvantaged, not sweeping across the society. But the numbers of people getting into trouble remain high, and we know that by emergency mentions that remained high despite the fact that drug use had gone down. I feel as if we should very quickly run through some of the issues in adolescent drug use. I think adolescence has to be seen as a developmental stage, and some of the things that go on are, until the age of 10, you pretend play. Kids are fooling around, acting like their parents. After the age of 10, it's real. They're actually trying to emulate the behavior of older people. Another issue is social. A major task of adolescence is developing autonomy, getting away from parents. At the same time that they're getting away from parents at the age of 10, 11, 12, they're becoming much more reliant on peers, conforming to peer pressure in various ways. Another element that I think is probably critical and has a great deal to do with our current prevention campaigns is using Piaget's terms. Piaget suggested that at the age of 10, 11, 12, you go from concrete operational thinking to formal operational or abstract thinking. What that means in essence, and I used my daughter actually for this, when my daughter was 8 or 9, she would sit in a car, and if someone lit a cigarette, or in a room, if someone lit a cigarette near her, she'd begin coughing extremely loudly and in a very obvious way. I can't stand it, I can't breathe. And the adults would say, shut up, be quiet, leave me alone, I'm not bothering you. And she'd cough and cough and cough until the adults stopped smoking. And I would feel great that I've raised this wonderful child who's never going to smoke cigarettes, never going to take drugs, and never going to engage in premarital sex. However, now she's 15, and she goes to prep school, and she's a skinny kid, and I can understand her wanting to have a cigarette in her hand to make her look, rather than 12, 14. Things are much more relative. Then it was absolutely wrong to smoke a cigarette. Now it's not so absolutely wrong. It's not great, it's not healthy, but people do it, it's not such a big deal. You think in much more relativistic terms. I mean, she's now at the age where she can understand literary metaphors, and she couldn't before. That's what drug use is about. Denial is kind of metaphorical. It's not going to happen to me. I'm just going to smoke this thing. It's kind of a cool thing. It's no big deal. I'm not going to get into trouble. Kids become introspective at this age, but remarkably egocentric compared to adults. And we all know this, but it's interesting that though we know it, how difficult it is to deal with some adolescents. For example, kids know that other people have lives apart from their own. They know that we have thoughts that aren't theirs, but the truth is they really do believe that they're the center of the universe, and that they have a great deal of difficulty separating their thoughts from the thoughts of others. These kids live in a world where there's an imaginary audience watching them at all times. Many of us know this, and that's why they are excruciatingly self-conscious, are willing to do almost anything to fit into the group, to merge with the group, because of that remarkable imaginary audience. What about risk-taking? We know that kids are risk-takers at this age. Some of it's hormonal, and some research has shown that it has to do with testosterone, but I think there's other things going on here. I think it has to do with the fact that rites of passage or initiatory rites in our society have become blurred. It's very hard for a kid to define himself or herself at the age of 13, 14, 15 when he or she knows that adolescence doesn't end till about 34 when you finish medical school and residency. And you're trying in some way to define yourself, to get control of the world, to show that you've got power. And the only ways to do that in some ways in our society, other than the empty religious rites that some people still go through, are driving cars fast, fighting, taking drugs, suicide attempts, early sexual activity, becoming pregnant. They look like risk-taking from one perspective. On the other hand, they're quite purposive, according to Jesser, in that they accomplish goals for these kids. They're defining themselves in some ways with respect to the society. It's interesting that we say they don't make risk assessments. I think they do make risk assessments. Their risk assessments are just different from ours. They're saying that the risk of being ostracized permanently from the group is way greater than the risk of smoking pot or doing a little coke or tripping on acid. The great risk is being pointed at and saying, you are out of the group, forget it, and then you head off to the ice flow. So what are the tasks of adolescents? Adjust to the physical changes of puberty, become independent from parents, figure out a relationship with peers, prepare for work, look in other people's eyes and see who they see. That's Erickson's terminology. Cope with feelings of alienation, powerlessness, and tremendous fear. Many of these kids have a realistic and pervasive dread of the future because they have no idea where they're going to fit. I mean, truly, they don't have any idea where they're going to fit or whether there's going to be a place for them. And often, their parents aren't saying, just relax, we'll bring you along, you'll be fine, just show up. And I promise you, the schools aren't saying, we'll bring you along, there's a place for you. So it makes sense for a kid to feel this anxiety about the future and look for ways to control it. Look for predictable, reliable sources of pleasure. And in that context, to me at least, it makes sense that a child would take drugs. And I think that if we were a little more sophisticated and we tested a lot of the populations of kids who were using drugs and not using drugs in certain areas, we'd find that the drug users, the kids who are playing with the drugs, are way healthier than the kids who aren't using the drugs in certain contexts. Not all, obviously. I'm just being provocative to a degree. But often it's reasonable behavior given the situation that many of these kids find themselves in. Let's look at risk factors again, just in terms of the research, because it's kind of interesting, and I'll run through it quickly.
Dr. Millman's remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 24, Number 10, returns to Robert B. Millman on substance abuse in adolescents.
The risk factors have been classified in various groups. There's cognitive and attitudinal. The cognitive would be that adolescents supposedly don't know the negative consequences of the drugs. That's nonsense. We know that. In fact, the negative consequences of the drugs have often been overrated in the press and the media, talking about how these drugs kill, and the kids know that their friends are not being killed. Personality factors, I just could go over some of the studies that have been done. Looking at heavy drug users, turns out that kids have, compared to non-drug users, lower assertiveness, low self-efficacy or self-esteem, low self-confidence, low social confidence, a sense of an external locus of control, that they're not masters of their fate. In addition to that, heavy drug users in the adolescent years seem to be more anxious, impulsive, rebellious. They're more impatient to appear grown up. They have a stronger need for social approval. They tend to be more dissatisfied and more pessimistic. That's just general, and that's looking at it from the point of view of a psychologist. Looking at it from the point of view of a psychiatrist, very interesting. To me, the most fascinating issue here is to look at the personality of a child and look at the drug use history and try to play with it to find some meaning there. So for example, a young kid, 12, 13, 14-year-old kid is one of these kids who comes to school every day and his papers are falling all over the place, his shirt's out, his tie's askew, everything's all over the place. Teachers say, yeah, he's a really good kid, but he can't pay attention, he can't get organized, he's just out of it. And the other kids are making fun of him. And we don't have to belabor diagnostic possibilities, but he could be an ADD child, or maybe he's borderline or something. At any rate, he's feeling extremely ill at ease. What then happens is he looks to take drugs, and his friends are smoking pot. So he tries pot. When he smokes pot, he feels as if his head is blowing off. He ends up in the hospital a couple of times. He tries acid, back into the hospital. Crazy thoughts, he hears voices, he's really out of his mind. Alcohol he finds to be very useful in that it battens him down, it makes him feel safer. He likes it. The trouble is that there aren't a lot of alcoholics or heavy drinkers in his high school, but there's a lot of pot smokers, and they're a cool group, and they accept aberrancy. So what this guy does is he starts drinking a lot and becomes a pot dealer. He can't smoke because it makes him too crazy. But what he does is he drinks to keep himself smooth, and then if he has enough alcohol in him and he's tolerant now, he can smoke some pot and it doesn't make him too anxious. A little bit after that, he finds heroin. It's around, it's available, and he tries heroin, and it's as if he's been waiting for heroin all of his life. He said, "It made me feel normal. My voice is quieted down, my anxiety was quiet. This was the best thing that ever happened to me. I knew my destiny was intertwined," and it's true, intertwined with heroin. Not only was he not interested in not doing it, but this was his destiny. He knew that he was going to be doing it for a long time to come. And what he then did is he was a pot dealer. He lived in that kind of subculture and did heroin to keep himself medicated. Continued use of heroin leads to depression, various sorts of withdrawal symptoms. So to me, the very interesting issue is looking at the interface of drugs, psychopathology, and history. And when you take a history from a young person, that's the way you do it. Rather than, do you take drugs, it's in an interesting, curious, reasonably empathic manner of someone who knows something about these substances. You're asking somebody else who knows a lot about the substances. In fact, that's all these kids know about. So I kind of laugh when you read about how kids hide their drug use or denial makes it impossible to take a history. I think the other way. I think that if you connect to a kid in a reasonable way, you can't stop them from talking because that's their subject. You know, they want to talk about it to somebody they think is knowledgeable. Related issue is that many of us are not so knowledgeable. And a way to think about kids is that they're insincerity seekers. They know instantly that you don't know the difference between a gram or an ounce, that you don't know how coke works or how crack works, that you don't understand the culture of the streets, and you're just talking about the disease of chemical dependency, and give me a break. So these kids, you know, they're not interested. On the other hand, if you're saying, well, what did you feel? How did it work for you? But some people get a little paranoid. Did you get paranoid? Oh, yeah. Well, how paranoid did you get? And what about anxiety? Did you ever end up in the hospital? So what'd you do to handle that? And then you get a drug history that fits in with the psychopathology, and it can be a remarkably interesting thing. And truly, and many of us have this experience, that you have to kick the kid out because they just want to keep talking about the drugs. And I mean, after a while, it's not a useful thing, but at the beginning, it's great to be interested in what they know so much about. At Payne Whitney, the way our conferences work is we'll present a case, and I'm sure it's like this in a lot of psychiatric hospitals. We present a case, and the resident will present the case unbelievably well. We have really great residents for about 30 minutes. And then after that, the psychologist will talk about the psychological testing, and they're great too. And then after that, the social worker will talk about family issues, and they're terrific as well. And then we've gone through an hour, and our professors' rounds are about an hour and 10 minutes. And invariably, every week since the beginning of time in psychiatry, we then say, oh, we don't have enough time to talk about therapy. You know, and you might think that that's an accident, but it really isn't an accident. It has to do with not having a lot to say sometimes, or being afraid to talk about it, and wanting to spend our time talking about descriptive issues. So what I'm going to try to do is force myself to talk a little bit about treatment and wrestle with these issues a bit. Just generally, when we're talking about the treatment of kids, clearly the therapist has to be interested, knowledgeable, reasonably, accurately empathic. I would argue that therapists have got to have a thorough knowledge of the pharmacology of the drugs in order to work with children. The way I often do it is I'll have the child come in with the parent, and the parent will tell me what the kid's problems are from the parent's point of view, and you're very polite with the parent and very polite with the kid, and then you usher the parent out after, or the parent's out after 10 minutes, and the kid is sitting there sullen. You can probably make a diagnosis from the way his hair or her hair is, and the belt, and also what kind of music they listen to. The kid is sitting there. You let the kid sit there for a while, and then you explain to the child that your plan is that you'd like to get the story, you'd like to find out how this kid lives, and the deal is that you will maintain the child's privacy and confidentiality unless you get frightened, unless you're afraid that the child or the kid is going to kill him or herself, in which case you've got to tell somebody. So it's not absolute privacy. You're going to tell, but you'll maintain the privacy. You work for the kid unless it's unduly dangerous. You then take this drug and psychiatric history that I mentioned before, lovingly going over each of the drugs and all of the psychiatric symptoms, if possible, to try to get some sense of it. Here's a woman injecting heroin into her subclavian vein. You have to know about heroin to know what this kind of desperation is about. She's got to find a way in. And that's very different from the situation with cocaine, and very different from the situation with many other drugs. She has to get that drug in, and she'll inject it there or into her vagina or into any other portal of entry. In John Phillips' book, he was in the Mamas and the Papas, he talks about how he had a gangrenous ulcer on his foot. And what he would do is just jam the syringe into this becoming gangrenous ulcer, because that was his only vein left, that was his only way in. Quite remarkable. You have to get the drug in. You have to know something about the pharmacology of heroin. Cocaine is the same. Cocaine is not addicting in the classical sense. It's what we call reinforcing. You don't want cocaine when you're in withdrawal 4 to 6 hours later. You want coke 30 seconds after you've just gotten high with freebase, or 5 to 10 minutes after you've just sniffed it. Very different ethos, very different pattern of abuse. Also, you might think about legalization. If the drug is most desired 5 minutes after you've just had it, or 30 seconds after you've just had it, and it's psychotomimetic, makes you psychotic, reinforcing and psychotic, how do you legalize something like that? Withdrawal syndrome from benzodiazepines, very different from cocaine or heroin. This is alcohol, minor withdrawal syndrome, DTs. I might call your attention to the so-called protracted abstinence syndrome. I think that with all of these drugs, there's a protracted abstinence syndrome that we have not appreciated until recently, and it's still very hard to batten down. For example, my prejudice is that after people have used heroin or coke for a period of time, they have changed their bodies. They have developed a neurochemical deficit such that they're different, they're altered, and it's not going to go back so easily. There's another way to look at it. We must know about the pharmacology of the drugs if you're going to be taking care of these kids. For example, looking at abstinence syndromes, alcohol, severe abstinence, quite consistent, so it's very physical. Depressants, same. Opioids, less severe, quite consistent. Cocaine, nothing going on, even though people talk about it all the time, and the consistency is not there either. So much of the withdrawal syndrome from cocaine depends on set and setting, who you are and where you are, as opposed to alcohol, where set and setting are clearly much less important. Here's another way to think about pharmacology, but let's think about it in terms of psychiatric terminology. With each of the drugs, there are acute effects, like with pot. At the beginning, quite variable, latent depression, anxiety, psychosis. Chronically, many people then develop depression, delusional syndrome, a so-called chronic cannabis disorder that you read about a lot, which I think is a very interesting thing, in fact. The literature talks about whether pot causes this chronic cannabis syndrome, which is apathy, lethargy, change in dress, inability to do well in school, poor concentration. And the literature is so interesting in that what they try to do is they try to make it the drug rather than the people. And the point of all of this is that it's drug interacting with personality that causes the effects. So the chronic cannabis syndrome would be drug use in a kid who's predisposed in a variety of ways to not be able to do his work. But it exists, and it's remarkable how many kids get derailed. Then there's acute withdrawal symptoms, and then there's protracted abstinence. And with each of the drugs, it varies depending on the stage. So the acute effects of alcohol, different from the chronic effects, acute withdrawal, different from protracted abstinence. And protracted abstinence, I must say, is interesting me tremendously these days, particularly in the young. A youngster uses cocaine for 2, 3, 4 years. At the beginning, gets a good deal of elation, really likes it, thinks it's great. After a while, notices that the cocaine makes him anxious, makes him really nervous, and then starts drinking in order to titrate against the anxiogenic effects of the cocaine. Then finds that the first hit of coke makes him want to take a drink or take a Valium or do some heroin. And he's saying to himself, this is weird. I used to be able to do all kinds of coke and I didn't get anxious. Now I need all this alcohol to titrate against the effects of a little bit of coke. And we would think that's the story. But the truth is, I think these kids are changing themselves by a process that we might call kindling and sensitization, where they're developing an anxiety disorder, de novo. So then the child says, this is not doing me any good. I got to stop this drug. This is horrible. I'm not taking coke anymore. Stops the coke, may continue drinking, but guess what? The anxiety continues. The protracted abstinence might persist for months or even years, and I think in there a remarkable research area to think about, protracted abstinence, how it's reflected in psychological syndromes. So you see the child, talk to him, get this history, skillfully, appreciating his experience and his pharmacologic knowledge, which is often difficult for therapists. Therapists like to know more about the disease than their patients, and in this case, the patients often know way more about the disease than the therapist. And it's reasonable to adopt that stance to say, tell me about it, I'm really interested. How does it work? What happens at a rave? What goes on at a Dead concert? Tell me about it, I'm really interested. And you should be, because it's quite a fascinating thing. And then they get going and they will talk about it. At some point, you have to decide what to do with the child and where to send them. These might be the indications for institutionalization. Presence of withdrawal symptomatology likely to be profound, medical or psychiatric conditions requiring close observation or life-threatening, for example, shooting heroin or even snorting it so that you've had a couple of overdoses, to diminish persistent denial or enhance the commitment to treatment, a home situation that reinforces drug use, repeated outpatient treatment failures, and the sixth one is the one that embarrasses me terribly, insurance coverage that necessitates inpatient care. I mean, it's horrible to put that up. It's like fraud made public. Anyhow, during these initial stages, my sense is to minimize confrontation. There's no reason to confront the denial with a kid. Rather, it might be better to empathize with the pain underlying the denial, so that when a child lies to you, which happens, and it happens all the time, what you do is you kind of go past it. You gloss over it. You say, well, maybe, or sounds funny, but just keep going. You come back later. You come back later that session or a week later and say, incidentally, that business about having stopped the coke or stopped the marijuana, that wasn't true. That couldn't have been true. I don't really believe that. While you're taking a history, while you're finding out about these kids, you also have to take a careful sexual history and a domestic violence history. And I must say that, as with drugs, your discrimination increases with knowledge. I run some programs in New York, and a few years ago, a number of our counselors went off and took courses in domestic violence and spouse abuse. Then they came back and felt reasonably comfortable asking about it, and the incidence of domestic violence and abuse in the home turned out to be remarkably high when you know how to ask and you know what you're looking for. I think the same thing goes for sex. If we're not comfortable asking about it, we don't get the answers. Same thing with drugs. And I think drug use and sex are inextricably intertwined. You have to find out what's going on sexually with these kids and how it fits with the drugs. For example, a reasonable syndrome would be a young girl is having her first sexual experience. She knows she has to do it because, this has to do with being a grown-up. She's scared to death. She's absolutely rigid with fear and anxiety. The way she learns how to do it is by drinking a fair amount or taking some sort of down or doing cocaine to disinhibit her. Or the young boy does the same thing, and if you take a careful history, you find out the most interesting stuff with these kids. Like, for example, one boy who was impotent, and with girls, they often can do it, though they're rigid with fear. With boys, they can't do it, and it's the most mortifying moment of that young kid's life. So the kid finds that he's impotent on a couple of occasions because of performance anxiety, and what he does is he finds that if he smokes some pot, he's able to get an erection. But then after a while, that doesn't work so well. But he finds that if he drinks 1 drink of alcohol, that works. 2 or 3 don't. But 1 drink of alcohol, a little bit of pot, a little tiny bit of coke, and he might be able to do it. So what he's doing is he's titrating his anxiety with the drugs, knowing that too much doesn't work, too little doesn't work, but his whole idea is to work on being able to be sexually responsive. And plus, the idea is that a male is able to do it 5 times a night. And he's able to just drive this woman wild. And on part of the young girl saying, how come the guy's not getting hard? I'm hideously ugly and terrible, and I'm the worst sexual partner of all time. The two of them using drugs to still these remarkable anxieties. So you have to take a very careful sexual history. Another syndrome that I think is critical to this, Erickson termed negative identity. That's the sense in kids that they've given up trying to be president or trying to be a social worker or trying to be a lawyer, and now the idea is to be how bad they can be. It's how bad you can be. They get elevated. Their prestige derives from being bad. And these kids will tattoo themselves in various ways. They'll put a skull and crossbones someplace on themselves because they're bad, and that's how good they are. And then the therapist or the program is coming at it from a totally different point of view of, don't you want to be a lawyer? Don't you want to get it together? We can help you. And this kid's playing a whole other game of how bad I am and looks at you like you are a Martian. And it's interesting, even when you know it, it doesn't do any good. You're doing everything in the world to charm this kid or seduce the kid or make her appreciate that you are interested in her, and she just thinks you're an idiot. Forget it. And she's not going to relent so easily, so it isn't so easy often to make a connection with some of these kids. At any rate, I started talking about phenomenology again. We have to talk more about treatment. Unfortunately, there are not so many good treatment programs around because most of the treatment programs are organized for grown-ups and think in a grown-up way. But we might think about what an ideal treatment program for kids looks like. The first level would be seeing a therapist who's sensitive to the child's values. Second issue would be some sort of a program if the drug use is more severe. And let's talk about an outpatient program. It has to have an ethos. It has to have a sense of identity that can compete with the sense of identity of the drug world. So it's got to have a name, it has to have some sort of symbol that a kid is belonging to something that's different from what they belonged to before. Has to be sensitive to developmental perspectives. You must have group process because these kids will take much more seriously what their friends say than what you say, but at the same time it can't be run by kids because kids are fascists and scary. And some of the worst programs I've ever seen have been run by children. And I'll just say there's one program where the kids took power, were in the ascendancy. And to visit that was to be chilled to the bone because you saw these bullies, scary kids who had no appreciation for psychopathology, certainly no appreciation for developmental issues, did know the 12 steps, blasting these kids with that, and it was a frightening specter to see that. So you've got to have groups, but the group shouldn't be run by kids. What about the model of treatment? Each one gives rise to a different treatment program. So for example, a sociologic model would say, well, kids use drugs because they have a lousy society, like Vietnam was a terrible place, and to get away from the hideous poverty and sense of powerlessness. Sociologic model would be a therapeutic community. Psychiatric model says you're self-medicating feelings of inadequacy or being borderline or taking heroin for its antipsychotic properties. Neurochemical deficit model would say, after Vincent Dole, who won the Lasker Award and should win the Nobel Prize, neurochemical model, deficit model would say, if you take a drug long enough, like I mentioned with cocaine, by a process of kindling and sensitization, or possibly by a process of endorphin suppression, but that's science fiction, and who knows, you change that person such that they develop a metabolic defect that will be expressed psychologically. They will have chronic anxiety, insomnia, depression, and they will have to continue self-medicating in order to stay even. You can't just stop the drug so easily. They have to self-medicate in order to stay even. 12-step model, we all understand surrender, powerlessness, and all the rest. There are a couple of other models. We might mention the gluttony model. You know, you're a pig, stop. This has to do with self-control. And the criminal model, which is you're a criminal and we should put you away, and we all recognize that's the #1 model in use in this country right now. 1.5 million people are in jail, 2 million are on probation and parole. This is a police state. That's the largest number of people who have been put away since the beginning of time, the largest number relatively and absolutely, and 70 to 80% of them are for drug crimes. It's a very interesting thing. So the criminal model is still the most important. At any rate, all of these different models exist, and each of the programs derives from a model. The funny thing to me, funny and sad, is that if you go to a therapeutic community and you say, what do you think about methadone maintenance, they spit. They say it's disgusting, it's horrible. If you go to a 12-step program and you ask them about methadone, they say, that's worse than heroin. So even though we know models aren't real, people live by them and take them very seriously. It's very hard to tell people all the models are true. The neurochemical deficit model is true. The psychiatric model is true. Sociologic model is true. Certainly a disease of chemical dependency 12-step model is true. And our job is to merge them to treat children. Work together with these different models. If you need medicine, you should have it. There should be a good psychiatric evaluation in TCs. A good way to organize programs might be according to 12 steps. But very hard for people to mix these models, particularly when someone has gotten sober through one or another of the programs. I mean, try teaching a counselor who's been to Betty Ford and now goes to AA a fair amount that he's got to appreciate that the psychiatric model or neurochemical deficit model, and he shouldn't insist at the beginning on this kid going to AA. Right. It worked for him, it's going to work for the kid. And it's remarkable how punitive we all can be defending our model. And models aren't real. They're just a construct. You know, we've just made it up. And they're all true, and they all obtain, and that's the way an adolescent program should be. So the idea would be to have a name on the door, to have group process, to have good psychiatric evaluation, to have people sensitive to the developmental ideas of kids, and to have it graded so that severe you can do intensive, less severe you can do less intensive. It's not one size fits all. Let's just talk about 12 steps for a moment. They don't work so well with kids. And guess why? You get a 16 or a 17-year-old kid, and in some ways you might see their situation as situational. I mean, they feel powerless, alienated, they're risk takers, they're having sexual problems, they have high anxiety, and they have attention deficit disorder, so they take drugs. And then you get them into treatment, and basically the message of 12-step programs would be, you have the disease of chemical dependency, and it's crucial that for the next 74 years, you never take a drink. All the kid was doing was smoking pot and doing some coke, and now for the next 74 years, this kid has got to adhere to the disease of chemical dependency. Clearly, it's life-saving for grown-ups. Some, but may not be so useful for the kid because the kid goes through the rehab, has to play the game, realizes that he has to play the game, otherwise he'll never get out or he'll end up in another one. But it's very hard for that child to say, I am powerless, because kids have a sense of invulnerability. It's very hard for the kid to surrender to a higher power if that's not the ethos, and I believe that maybe the single most important part of AA is surrender and accepting powerlessness, and that's very difficult for some of these kids. So maybe that's useful, but it shouldn't be our first line with these children, and certainly we should have other tracks that might lead to the 12 steps for the kids where it fits. But the idea to insist on that form of treatment for all of these children makes no sense to me at all. So the idea would be to meld a therapeutic community approach, group process, with reasonable sensitivity to developmental issues, and add on some spiritual values that AA has done so well. And any one of those by itself is not good enough. A psychiatric model is so inadequate because there's no group process. You bring a kid into a psychiatric hospital, comes in alone alienated, leaves alone alienated, hasn't made contact with any people. An outpatient psychiatric program is generally alone and alienated, and you stay that way. And the idea is we're trying to create a group process that's acceptable to these children. I'm playing around with words because I think a lot of the people in the audience can do it better than I can. But guess what? There aren't any programs like this in the country that are so good. There is not a great model for treating adolescents. I should say something about therapists as well. The other thing we do is we believe in technology. We think that if you use penicillin on penicillin-resistant organisms, it goes away. And methadone, I think, is a remarkably useful thing for heroin addiction because heroin addiction is so profound. But the tendency is to think that it's not the people, it's the drug or the procedure. So it's the TC or psychotherapy or psychoanalysis rather than the people. And I just want to remind you that there are healers in our midst. I think I used to be one. There are healers in our midst who are able to make connection with people and who are able to do really good jobs with these kids, and there are others who are less good at it. And it has to do with sensitivity and how hard you're trying and how insecure you are that you keep trying day after day and possibly not being pompous, or in other cases, being correctly pompous. There's a magic there in some therapists who are able to relate to children, and we haven't identified it so well. And just to give you an idea of how primitive it is, what we know about therapist-patient relationships are we know that people get better if the therapist likes the patient and the patient likes the therapist. I mean, that's where we're at. How about that? And that's true, but at the same time, we are overly relying on this technology, on the models, and not appreciating enough of that it ends up being a relationship between a youngster or a group of youngsters and some grown-ups.
Thank you, gentlemen. Audio Digest Psychiatry is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1995.